Today we are talking about rheumatoid arthritis. So what is rheumatoid arthritis? It is a systemic, which means it goes throughout the body, autoimmune disorder. It attacks the joints in the synovium. In people with rheumatoid arthritis, most of the time they will have rheumatoid factor, and this will lead to tissue destruction. Rheumatoid factors are antibodies, autoantibodies that react with immunoglobulin antibodies found in the blood. It's hypothesized that the interaction between rheumatoid factor and the immunoglobulin triggers events that initiate an inflammatory reaction. So this inflammatory reaction causes an infiltration of T lymphocytes into the synovium, which causes synovitis. This is why rheumatoid arthritis is known as a chronic inflammatory disease of the lining of the joints and internal organs. And there is increased osteoclastic activity. This means that the osteoclasts are active highly, and what they do is they take the calcium from the bone and release it back into the bloodstream. So what this does is cause an erosion of the bone. Also, there's a pannus, which is a result of the thickened synovium, and what this does is this is granulation tissue that grows into the joint space and it will cover the cartilage. This will cause the cartilage and the bone to erode. And in rheumatoid arthritis people, it will start in small joints and feet and usually affect same joints on both sides of the body. At a cellular level, the fibroblast-like synoviocytes, which make up the synovium, are important in the pathogenesis. The macrophages, they release cytokines, and they stimulate the FLSs, which are the fibroblast-like synoviocytes, and when they proliferate together with the cytokines, they stimulate the osteoclasts, which lead to the bone erosion. So the FLSs secrete proteases, which break down the cartilage. So you have a breakdown of cartilage, you have a breakdown of bone, decreased bone the joint marginal space, and that can lead to immense pain and the bones rubbing together. So who does it affect? 1 to 2% of the United States population, which doesn't seem like a lot, but that's about 2.1 million individuals. Also, 30,000 to 50,000 children under 16, and usually a higher rate of women to men at a ratio of 3 to 1. Rheumatoid factor is found in roughly 80% of individuals with rheumatoid arthritis, and more than 90% of RA individuals develop symptoms in the foot and ankle over the course of the disease.
In the upcoming clips, we will be analyzing the gait of a patient with an ankle fusion secondary to RA. You will notice that Derick and I have taped and wrapped our ankles to better simulate the fused ankle by limiting the motions of dorsiflexion and plantar flexion, which are the exact motions that are limited when the ankle becomes fused at the true ankle joint, which is the talocrural joint. In this first clip, we are analyzing Derick's gait. Due to the fused ankle, we are going to have minimal heel strike due to the lack of dorsiflexion. Additionally, since the right ankle is the involved ankle, the left step length is going to be shorter than the right due to the lack again of dorsiflexion in the right ankle. We will also see a quicker stance phase on the right, and we might see some slight circumduction of the right lower extremity due to that lack of motion. This will be the most common presentation of the gait of a patient with a fused ankle secondary to RA. In this clip, we are seeing an extreme toe out. Since there is limited dorsiflexion and plantar flexion, the patient may try to compensate for the lack of their ankle rocker by turning their foot outward and externally rotating the lower extremity. This will allow the patient to use the midfoot to propel them forward instead of their ankle. They will do this through pronation. This, of course, assuming the disease process hasn't affected the midfoot yet. This next clip is similar to the last clip, except of toeing out, the patient will be toeing in. This will also help compensate for the lack of the ankle rocker, allowing the patient to propel forward by supinating the midfoot. However, we will not see this occur if the midfoot is affected by the disease process. This clip shows that another way to compensate the lack of the ankle rocker is by using the forefoot. It will look like the patient is going on their tiptoes. The patient has some plantar flexion, but that is restricted as well. They will use their forefoot as their rocker to help propel them forward. Again, this will not occur if the disease process has affected the forefoot as well. The last compensation we may see is the patient hyperextending the knee and anteriorly tilting the pelvis. This will put the body in front of the ground reaction forces to use gravity and the momentum of the patient to overcome the lack of the ankle rocker to propel them forward. This is the second most common pattern we will see patients do in order to overcome the lack of their ankle range of motion. To better improve their gait, we can give them a cane or walker to help with balance. However, we might need to give them an assistive device that alters the handles if the disease process has affected their grip. Some patients may benefit from rocker bottom shoes as well to help overcome their lack of ankle range of motion. Additionally, we can try to provide exercises to help with lower extremity strength and balance and help promote range of motion through various exercises as well. We might not be able to get a ton of range of motion back, however, we can certainly improve it as any little bit will help.